So up next, I want to talk about some specific psychological disorders. And in this section, we'll talk about anxiety and mood disorders, as well as suicide. Now, I want you to keep in mind that you are getting the crash course. The DSM-5 is 900 some pages. We simply don't have time to cover everything. So what I want to do is highlight some of the more common or well-known disorders. There's entire courses that give a much broader range of disorders like psychopathology or abnormal psychology. But this is just an intro class. And as I said at the beginning, I am not a clinician. So my goal is to give you an overview rather than an in-depth exploration. Up first is anxiety disorders. These are a class of mental disorders that distinguish themselves from other problems via two key features: fear and anxiety. Fear is an emotion experienced in response to an imminent threat, whether that threat is real or imagined. Anxiety, on the other hand, is an emotional state experienced in anticipation of a potential future threat. Anxiety disorders are among the most prevalent mental disorders. In fact, 32% of individuals experience an anxiety disorder at some point in their lives. That is one in three people. That is quite high. Anxiety disorders have a pretty early onset, which means that it's diagnosed early in life. Actually, the average age of onset for an anxiety disorder is 11 years old. What's interesting and what a lot of people don't realize about anxiety is that it can actually be quite adaptive in small doses by signaling us that something is wrong, helping us to solve problems, or putting us in a heightened state to prepare. For example, if you are giving a class presentation. But in large doses, anxiety can become problematic and can spin out of control and become excessive or inappropriate. And that's when it becomes diagnosable and problematic. Up first, I want to talk about a specific anxiety disorder, which is known as generalized anxiety disorder. The median age of onset here is 30 years. So this is later than that of other disorders. But GAD, generalized anxiety disorder, can occur at any point in the life cycle. Women are about twice as likely to develop GAD over the lifetime as men. Women experience anxiety more frequently. Therefore, experts recommend routine anxiety screenings for women and girls aged 13 and older. GAD is actually the most commonly occurring anxiety disorder in older adults. New onset GAD in older adults is commonly related to co occurring depression, which we'll talk about in a little bit. So, in this age group, GAD has historically likely been underdiagnosed and undertreated. To meet formalized diagnostic criteria for GAD, excessive anxiety and worry must be present most of the day, more days than not, for at least 6 months. So this means if you have a big presentation and the couple of days leading up to it, you're feeling super anxious, that is not generalized anxiety disorder. The disorder is persistent and pervasive. Features of excessive worry include worrying even when there's nothing wrong, worrying about a perceived threat in a manner that is disproportionate to the actual risk, worrying about something for the majority of your waking hours, asking others for reassurance about your specific concern, but continuing to worry anyway, and worry that shifts from one topic to another. Now, these topics of worry tend to involve typical life circumstances or stressors like health issues or financial matters or starting a new school or job. For people with GAD, the worry is extremely difficult to control and is associated with multiple physical and cognitive systems like fatigue, impaired sleep, irritability, restlessness. GAD can be challenging to accurately identify because, as I've said, anxiety is an emotional state that everyone experiences from time to time in pretty typical response to the stressors of everyday life. The diagnosis of GAD occurs, however, when anxiety crosses a threshold of excessiveness and stays there for extended periods of time. So, in these cases, the anxiety, worry, or other symptoms make it extremely challenging for the person to fulfill responsibilities on a daily basis, leading to strain in personal relationships or problems at work or school. Like many other disorders, GAD is thought to emerge in the context of particular biological and environmental factors. A key biological factor is genetic vulnerability. So it's estimated that one third of the risk of experiencing GAD is genetic. But genetic factors may overlap with other anxiety and mood disorders, particularly major depression. No specific environmental factors have been identified as specific or necessary to cause GAD, but things like overprotective parents and periods of prolonged stress have, in fact, been linked to GAD. So, in other words, GAD is not caused by any one factor, biological or environmental. Rather, the disorder is thought to result from a perfect storm of environmental stressors that occur in an individual who already has a genetic predisposition for anxiety. Remember, we talked earlier about that gene by environmental interaction. This is a good example of that. Social anxiety disorder is a common but largely underdiagnosed mental health condition experienced across different age groups and cultures. People with social anxiety disorder have an irrational fear of being watched, judged, or embarrassing themselves. The anxiety and discomfort becomes so extreme that it interferes with daily functioning. So, while this can be debilitating, appropriate treatment recovery is possible. People with social anxiety disorder know that their fear is out of proportion to the actual situation, but they're often still unable to control their anxiety. The anxiety may be specific to one type of social or performance situation, or it might occur in all situations. Some common triggers include interacting with strangers, making eye contact, initiating conversation. People with social anxiety disorder may experience cognitive, physical, and behavioral symptoms before, during, and after these social situations, such as worrying that you'll be judged by others, fear of becoming embarrassed or humiliated, profuse sweating, racing heart, or avoidance of social activities or running away from social activities. Panic disorder is a type of anxiety disorder that is characterized by intense, recurrent, and unexpected panic attacks. Now, fear and anxiety can be normal reactions to specific situations and stressful events. Panic disorder differs from this normal fear and anxiety because it's extreme and often strikes out of the blue. So, a person with panic disorder may experience symptoms such as severe feelings of terror, rapid breathing, increased heart rate. People with panic disorder often experience these attacks unexpectedly and for no apparent reason, but they can also be preceded by some sort of triggering event or situation. Approximately 2.7% of the US adult population experiences panic disorders each year, and almost half, about 44.8% of those individuals experience cases of panic disorder that are classified as severe. To be diagnosed with a panic disorder, a person must experience recurrent and often unexpected attacks. So, in addition, at least one attack needs to be followed by 1 month or more of the person fearing that they'll have more attacks. Now, it's important to note that you can have a panic attack without having panic disorder. So, sometimes people with GAD or other disorders have a panic attack. The key difference is that with panic disorder, the attacks are recurring. Although the exact causes of panic disorder are not clearly understood, many mental health experts believe that a combination of environmental, psychological, and biological factors play a role. Panic disorder typically develops between the ages of 18 and 35, and we know that women have more than twice the risk of panic disorder compared to men. There are some clear genetic links. So, if you have a close biological family member with panic disorder, you are much more likely to develop the condition. Although up to half or more of people with panic disorder do not have close relatives with the condition. So, it doesn't necessarily mean that having a close family member means that you will be diagnosed. It just means that you're a little bit more likely. Environmental factors may also play a role, such as experiencing a traumatic event, or being the victim of some sort of an abuse. These can also increase the risk. Even something like a life transition can be the cause. Things like the death of a loved one, divorce, marriage, or having a child, or losing a job may also increase the risk. So I have a video here that shows an idea of what it feels like to have a panic attack. Now, obviously, it is different for each individual, and even the same individual, their attacks might manifest differently. But I like this video because I think it serves to at least give you some idea of what it feels like.
panic attack goes from 0 to 100 in an instant. It's halfway between feeling like you're faint and feeling like you'll die. If you miss a step on the stairs and your stomach lurches, it feels like that, but lasts much, much longer.
Fighting for breath, feeling like the floor's unstable.
Trapped in your own head while floating somewhere outside, looking back at yourself, wondering what you're doing. A huge fist grabs hold of my insides. My heart goes into overdrive and I go through the motions in autopilot. Like when you're in a dream and you're screaming, but you can't make any noise.
Your entire body is feeling everything and nothing all at once.
And you just want to jump out of your skin, get away from this feeling.
But I just keep thinking, this will pass. This will pass.
And it usually does.
All right, sorry in advance for the scary pictures. A phobia is an irrational and excessive fear of an object or simulation, or situation. In most cases, the phobia involves a sense of endangerment or a fear of harm. Phobias are among the most common mental illnesses in the United States. The National Institute of Mental Health suggests that 8% of US adults have some type of phobia. Women are more likely to experience phobias than men. Typical symptoms can include nausea, trembling, rapid heartbeat, feelings of unreality, and being preoccupied with the fear object. The American Psychiatric Association defines phobias as anxiety disorders and categorizes them into 3 different types. So agoraphobia describes a fear of being trapped in an inescapable place or situation. So as a result, the phobic individual may begin to avoid such situations. In some cases, the fear can be so pervasive and overwhelming that they even fear to leave their home. Social phobias involve a fear of social situations and includes an extreme and pervasive fear of being placed in a social setting. In some cases, this fear may center on a particular type of social situation, such as public speaking. But in other instances, people may fear to perform any task in front of others for fear that they will somehow be publicly embarrassed. Specific phobias involve the fear of a particular object, such as snakes or spiders. Such phobias typically fall into one of 4 different categories: situational, animal, medical, or environmental. A few common examples of fear objects include spiders, dogs, needles, natural disasters, heights, and flying. So when people talk about having a phobia of a specific object, such as spiders, they are referring to having a specific phobia. All right, let's get away from the scary picture with the spider and the clown. As you see here, there's the 4 major categories of specific phobias. There's natural environments, so things like fear of lightning, water, storms, tsunamis, mudslides. Animals is fear of things, animals, right? Snakes, rodents, cats, birds, spiders. Medical, so fear of seeing blood, visiting a doctor, getting a needle, having blood taken. And then situational, so fear of bridges, leaving home, driving, heights. Now, before you all go on diagnosing yourselves or your friends with specific phobias, let's remember that phobias involve intense fear of an object or situation that's greatly out of proportion to its actual threat. For something to be diagnosed as a phobia, it has to go beyond minor dislike or fear. It has to restrict our lives, create considerable distress, or both. Now, I don't like spiders. I think they're creepy and crawly and gross. And if my husband is home and I see one, it is totally his problem to deal with. But if he's not home and there's a spider, I can get it myself. I'm not going to be happy about it, but I'll do it. My feelings towards spiders represent a normal, non-pathological dislike. It would be a phobia, on the other hand, if I simply couldn't even handle being in the same room as the spider, or I had to leave the house because I was so distressed by it. Things like that. So phobias are an unrational, unrealistic sort of fear. My dislike for spiders is kind of annoying, but doesn't really impact my life in any major way. We don't always know why disorders occur or where they come from, but we do have some theories. Some learning theorists believe that fears can arise in two ways: by observing others engage in fearful situations. So maybe you saw someone you know get bit by a dog, prompting your own fear and anxiety of surrounding dogs, or from misinformation from others. Perhaps your parents were a bit too emphatic about not going out in a thunderstorm, facilitating your fear. Other learning theorists offer explanations focused on operant conditioning or reinforcement and punishment following behaviors. So, learning models focus on acquiring fears via classical conditioning and maintaining them through operant conditioning. So, if someone has a fear and they avoid a situation where they think the fear might be triggered if they avoid it, they then learn that by avoiding the fear, it kept them from having the panic attack or from feeling the distress. So, they would continue to engage in behaviors in the future to avoid that fear, sort of creating this cycle. Anxious people also tend to think about the world in different ways than non-anxious people. They're involved in quite a bit of catastrophic thinking, predicting terrible events despite low probability of happening. Ever hang out with that person who's always worried about everything? Well, what if we go outside and what if it rains and then what if we get pneumonia? Okay, that's sort of characteristic. There's also anxiety sensitivity, so a fear of anxiety related symptoms that many of us don't experience in our lives, so perhaps we don't act these ways. There's also a lot of research suggesting that in addition to environmental and cognitive aspects, there's genetic influences as well. We talked a little bit about this on the previous slides. Many anxiety disorders are genetically influenced through high levels of neuroticism or the propensity to demonstrate negative affect. Now, post-traumatic stress disorder used to be categorized as an anxiety disorder. However, in the DSM-5, it was moved to a group called trauma and stress-related disorders. But for the sake of simplicity, I'm still going to talk about it here, sort of vaguely lumped in with the anxiety disorders. People who live through a traumatic event can find themselves experiencing emotional challenges long after the event is over. Although it's common for people to experience emotional challenges after trauma, their symptoms can lessen in intensity over time as they continue to heal. Now, people with PTSD find themselves experiencing symptoms that continue to cause them significant distress. PTSD is a marked emotional disturbance after you experience or witness something that's severely stressful. PTSD can develop after the experience of a traumatic event, either a single isolated event or more chronic and recurring traumatic experiences like repeated childhood sexual assault. A variety of emotional disturbances and symptoms are associated with PTSD that cause clinically significant distress or impairment in the person's social interactions, their ability to work, or other important areas of functioning. It's estimated that there are currently around 8 million people in the United States who are living with PTSD. Although it is altogether, it is estimated that 7 to 8% of people will experience PTSD at some point during their lifetimes. About 70% of adults in the United States have reported experiencing at least one traumatic event in their life. So, with this in mind, it's important to note that most people who experience a traumatic event will not develop PTSD. Some factors that contribute to the likelihood of developing this disorder include things like a pre-existing mental or physical health condition, the type of trauma, and the experience of additional stressors that occur after the trauma. So, for example, somebody who experienced sexual violence, who then takes their perpetrator to court and has to continually interact with them over and over again, might experience that might be considered additional stressors that occur after the trauma itself. To qualify for diagnosis of PTSD, the event must have been dangerous or life-threatening, either to yourself, so experiencing an assault, or to someone else, so maybe you witnessed an assault. This is the only disorder that requires some sort of trigger or traumatic event to be categorized as a disorder. Symptoms include flashbacks, recurrent dreams, avoiding reminders of the trauma, and increased physiological arousal in different situations similar to the trigger or panic attacks. We see this a lot in veterans, people who return home from war, who, if they hear a car backfiring, it might trigger stressful situations of being at war with the gunshots. Okay, a good example of this is for those of you who watched Downton Abbey. There was a character early on, Mr. Lang, who was away at war, and at the time they would call it shell shock. But you saw him experiencing severe distress to loud noises. He experienced these flashbacks and recurrent dreams, and it can be a really debilitating problem. Moving on now to talk about obsessive compulsive disorder, or OCD. This is a mental health condition categorized by obsessions and compulsions that interfere with daily life. Now, again, OCD was formerly classified as an anxiety disorder because people affected by this mental illness often experience severe anxiety as a result of their obsessions. They may also engage in extensive rituals in an attempt to reduce the anxiety caused by obsessions. But in the DSM-5, OCD was moved to its own disorder class of obsessive compulsive and related disorders. Symptoms of OCD usually appear gradually and can be long-lasting if not treated. So people will experience obsessions, compulsions, or both. And these symptoms interfere with many areas of life, including school, work, relationships, and normal daily functioning. Obsessions are thoughts, images, or ideas that are unwanted, won't go away, and are distressing or worrying. So, what if I become infected with a deadly disease? Or what if I hurt someone? Some common symptoms of obsessions include aggressive thoughts about other people or oneself, a need to have everything in a certain order, fear of germs, unwanted thoughts or forbidden or taboo topics such as sex, religion, or harming others. Compulsions are behaviors that must be done over and over again as a means of relieving anxiety. And they're related to obsessions, right? So, for example, if you are obsessed with being contaminated, you might feel compelled to wash your hands repeatedly. However, this is not always the case. So some common compulsions include counting things over and over again, excessive washing or cleaning, ordering things in a particular or symmetrical way, or repeated checking, such as checking that the door is locked or the oven is off. Now, again, before you start diagnosing every organized person as having OCD, remember that it's not a disorder unless it is markedly influencing or interfering with your life. Okay, so OCD is marked by repeated or lengthy, like hour-long or day-long immersions in these obsessions, compulsions, or both. I want to show you a quick video about someone's experience of what it's like to live with OCD, because it's one thing to talk about these disorders, but it's another to hear from somebody who's actually living in those shoes. So let's take a look here.
4, 5, 6. How long did I sleep for? I got to bed at 3. Let's see, 3 o'clock. I hope I didn't do anything stupid yesterday. 4, 5, 6, 7. How many hours did I sleep? How long did I sleep for? 3 a.m. 2, 3, 4, 5, 6, 7. I'm feeling lightheaded. My heart's a little lightheaded. I'm feeling lightheaded. I don't feel good. My heart's beating. I don't know if I feel all right. I think I feel all right. I'm okay. Yeah, I feel all right. No, I feel fine. I don't know if I should take my meds. I should take my meds. Should I take my meds today? The medicine's working. It's going to work. The medicine's working. I should stay on the medicine. How do I know if the medicine's working? I don't know. Should I take meds today? How many hours did I sleep last night? I didn't get enough sleep. 2, 3. My pulse is slow. 4, 5, 6, 7, 8. It's fast. Pulse is fast. Just slow. 17. Can you pulse be too slow? 10, 11. 12, 13. My appetite really isn't there. I hope it's okay. I don't really have an appetite. It's not great. I'm sick. You're fine. Maybe I'm too hungry. I shouldn't be this hungry. Oh God, I'm too hungry. It could be my thyroid. That's why I'm sick. It could be my heart. My heart is my thyroid. You know what? I'm gonna write. I'm gonna go write. 4, 2, 3. Looking forward to writing. 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. I'm looking forward to writing today. I can't wait to write today. To write. It's coming. It's flowing. I'm writing very well today. Story. I'm gonna write a lot. I'm gonna write so much today. I'm loving this. Great. My stomach's really hurting right now. My stomach's really hurting right now. I hope it's not Ebola. I was on a plane recently. I hope it's not Ebola. I need to look up the symptoms.
Okay, I think you get the idea.
Could be Ebola.
Let's move on to next talk about mood disorders. So they're called such because people with mood disorders experience struggles in their everyday lives based on their mood. which then influences all aspects of existence. So one major category of mood disorders is depressive disorders. Over 20% of Americans will experience a depressive disorder in their lifetime, and they typically develop during one's 30s. They're more prevalent among females. In fact, females are twice as likely to develop a depressive disorder compared to males. And this could be because women are more likely than men to ruminate or fixate on negative things. But it could also be associated with gender differences and power imbalances associated with patriarchy. There are a number of different depressive disorders, such as disruptive mood dysregulation disorder, major depressive disorder, etc. But let's talk a little bit more about major depressive disorder, as that is the most common. So symptoms can develop suddenly or gradually. Hang on. Yeah, but they're often recurrent. They happen again and again over time. With major depressive disorder, you have these episodes of more depressed periods. So the average episode lasts 6 months to 1 year. Most people experience 5 to 6 episodes throughout their lifetime. And after the episode is done, they go back to semi-normal functioning. MDD can cause extreme functional impairment across different life domains: school, life, relationships. The simplest tasks like getting out of bed and putting clothes on can become very challenging. A major depressive episode is a state in which the person experiences lingering depressed mood or diminished interest in formerly pleasurable activities. In order to be classified as having MDD, a person must meet certain criteria. So first, the depressed mood or diminished interest in formerly pleasurable activities. Those are mandatory. They must also experience at least 5 of these symptoms for more than 2 weeks, nearly every day. Okay? So remember how I said earlier with the DSM about how it's not just, oh, if you have this symptom or that symptom. It's actually quite a complicated process of diagnosis. Common symptoms include sleep difficulties, fatigue, loss of energy, appetite or weight change, psychomotor issues, difficulty concentrating or making decisions, excessive feelings of worthlessness, guilt, self-blame, thoughts of death or suicide. Depression produces severe impairment. In some cases, people may fail to take care of their basic health needs like eating or showering, which are major red flags of a depressive disorder. So let's take a look at this video to hear from a young woman with MDD about what some of her experiences have been like.
My name is Julia and I'm 19 years old. In 2017, was diagnosed with major depressive disorder. I almost lost this battle. I didn't think it was gonna get better, but it did. I've had anxiety since I was a little kid. I always had this feeling that something terrible was gonna happen, and that presented itself in tightness in my chest. I'd get really shaky. I would have a lot of stomach pain. Those were the physical ways that it came out. For the longest time, I didn't know that was my anxiety. I just knew that was something that happened to me. Around middle school, I started to get depressed, and it progressively got worse as I got into high school. Everything just seemed kind of gray. And a lot of worthlessness too. I don't have anything to offer. From the outside, I think I hid it pretty well. I was a straight A student. I hung out with my friends. I babysat all the time. I was involved in my church youth group. I didn't let people see that there was something going on. That was what stayed closed behind my bedroom door. Things started to feel more heavy. I started to self-harm as a way to cope. I started having suicidal ideation. I told my mom, I don't think I can keep myself safe. And I know my parents were shocked when they knew how bad it actually was. It was on a Sunday night. My mom called Children's, their hotline. I was evaluated by a social worker. And I think it was honestly the first time I was completely open about what was happening. And I told my social worker that I didn't necessarily want to die. And I knew that I needed a break from what was happening, from all the things I was feeling. And death seemed like the only option. I just remember crying to her and being like, I don't know what else to do. Like, I'm stuck. Here I was completely broken. I could barely see the point in staying alive. I felt so ashamed of myself. And these people, they just treated me like a person. I felt validated and I had some hope. And like, I knew that like, okay, when I ask for help, help is given and it works. And I knew that this break I was looking for could be found in a hospital room instead of dying.
And again, remember that all episodes are going to be different. Each person is going to experience them differently. But I like to give you at least some examples of, sort of a day in the life. In order to fully understand depression, we must appreciate the complex interplay of inborn tendencies, stressful events, interpersonal relationships, loss of reinforcers in everyday life, negative thoughts, feelings of helplessness, etc. There are many, many, many different models to explain depression, but so let's go through some of them. First is stressful life events that represent loss or threats of separation, such as death of a loved one or a divorce. These are especially tied to depression. A crucial determinant of whether we may become depressed is whether we've lost or are about to lose something we value dearly, like social support, financial support, self-esteem, or if we're going through a divorce, losing our loved one. Interpersonal models suggest that people with depression tend to stir up negative feelings in others as well. So a lot of people will talk about depression contagion, and there is some truth to that. So one of the characteristics of depression is something called rumination, which is chronic fixation on something. So if you do have someone who's supporting you, you might engage in what seems like a helpful chat about your life and your experiences, about the excessive discussion and fixation on your stressor can actually play a negative role in stirring up negative feelings in others or reinforcing them in yourself. Constant worrying, mistrust, and socially inappropriate behaviors can also be a social turnoff to people. So there might be less opportunities to engage in rumination. Many people tend to lose interest or get frustrated with people who are depressed. Episodes that occur in MDD may result in people getting frustrated because the individual will go from, quote, normal to depressed as they swing back into another episode. It can be very frustrating and disorienting for those around them who may not understand what they're going through. Behavioral models focus on reinforcement and consequences. So from this perspective, depression may result from a low rate of response contingent positive reinforcement in the environment. What do I mean when I say response contingent positive reinforcement? Well, people with depression often stay in the house, they avoid other people, they sleep a lot, they isolate. So this precludes their ability to engage in any sort of situation or scenario where they could experience positive reinforcement, like going to a movie or hanging out with friends. People with depression experience a loss of interest in things they once enjoyed. So they may try to go play soccer or go play tennis or, go to a play, but they don't find it fun. So they stop doing it, which then eliminates their ability to access that reinforcement. Aaron Beck's cognitive model of depression holds that depression is caused by negative beliefs and expectations. He talks about a cognitive triad of negative views of oneself, the world, and the future. This cognitive triad represents the three major components of depressed thinking. So basically, depressed people think negative thoughts about everything, which then leads to their feelings of depression. Beck further suggested that people with depression engage in cognitive distortions where they put a negative spin on everything, like that constantly viewing the glass as half empty instead of half full. We'll talk more about Beck next week, when we get to treatments. Still, other models described a phenomenon called learned helplessness, which is the tendency to feel helpless in the face of events we can't control. Researchers have noted some striking similarities between the effects of learned helplessness and depressive symptoms. Both are associated with passivity, appetite changes, weight loss, and difficulty learning that one can change their circumstances for the better. Seligman and colleagues argue that people prone to depression attribute negative outcomes to internal factors and positive feelings to external factors. So when something bad happens, they think it's because of something they did, it's their own fault, it has to do with them. But when something good happens, they attribute it to chance or luck or a fluke. Depression also has some genetic components. It's associated with low levels of the neurotransmitter serotonin, and people who inherit 2 copies of this stress-sensitive gene are actually far more likely to develop depression following a stressful event than people with a different version of the gene that are less sensitive to stress. Many patients with depression have decreased levels of dopamine as well, which is a neurotransmitter that's closely tied to feelings of reward. Next up is bipolar disorder. This is a mental health condition defined by periods, better known as episodes, of extreme mood disturbances. Bipolar affects a person's mood, thoughts, and behavior. Now, there's two main types, bipolar 1 and bipolar 2. Individuals with bipolar 1 experience at least one manic episode in their lives. Although not required for formal diagnosis, the vast majority will also experience major depressive episodes during the course of their lives. Individuals with bipolar 2 have at least one hypomanic episode, which is a less serious form of mania, and at least one major depressive disorder. Now, in general, bipolar is marked by both depressive episodes, which we just talked about, and these manic episodes. So a manic episode is an experience marked by dramatically elevated mood, heightened self-esteem or grandiosity, increased goal-directed activity, decreased need for sleep, impulsivity, and it's not just a few days. Manic episodes last at least a week. So during a manic episode, people tend to engage in a lot of risky behavior. They might quit their job or have a lot of risky sex or buy a lot of things, just impulsively shopping. They tend to lose all inhibition and reason and sort of just go hog wild. During a manic episode, people have ideas which race through their heads very quickly, which may account for heightened rates of creative accomplishment in some individuals with bipolar disorder. Now, contrary to popular belief, although experiencing mania can result in a person becoming violent or dangerous, that's not necessarily the case. An individual experiencing hypomanic episodes may experience similar symptoms, but their functioning won't be as impaired. Many individuals who experience hypomania associated with bipolar 2 enjoy the increased energy and decreased need for sleep. An episode of hypomania does not escalate to a point where the person needs hospitalization, which may happen with a person experiencing mania, especially if they're becoming a danger to themselves or others. Bipolar disorder is equally common in men and women, although it's much less common than depression. The difference between depression and bipolar disorder is mania. So if you have a depressed individual, as soon as they have one manic or hypomanic episode, their diagnosis shifts from depression to bipolar disorder. So that's the differentiation. Some people will have one manic episode, but then not experience another one for years. Other people will have a series of manic episodes, one after another, very quickly. And manic episodes often produce some pretty serious problems in social and occupational functioning. It can be really hard to go to work or to school or to focus. While the exact cause of bipolar 1 disorder remains unclear, genetics is believed to play a major role. This is evidenced in part by studies of twins in which one or both had a bipolar 1 diagnosis. So in 40% of identical twins, or those with identical gene sets, both twins were found to be bipolar compared to less than 10% of fraternal twins who don't share all the same genes. Other contributing factors include abnormalities in brain circuitry, irregularities in neurotransmitters, and environmental factors such as childhood trauma or abuse. Stressful life events are also associated with an increased risk in manic episodes and more frequent relapse and longer recovery from episodes. Often what happens, back to that environment by gene interaction effect, is that people have a genetic predisposition for bipolar disorder, but then it gets kicked off or activated by a stressful life event. So I won't show this whole video, it's kind of long, but I love this because it is a girl who actually caught her manic episode on tape. So it sort of gives you an idea. You can see her behavior and how she is just all over the place, going a mile a minute. So let's take a look.
Stockholm Syndrome by Wonder. Hello, hi. Okay, so as you guys can tell by the title, this is a video in which I show you guys myself having a manic episode. So obviously, like right now, I'm not like super duper crazy manic where I'm having like a crazy episode. I'm just almost normal right now, but a little while ago, like it was nighttime, and I got really, really manic, and I thought to myself that I had this genius realization that the One Direction song Stockholm Syndrome just perfectly describes mania, and I needed to just like
write it down, and my hands were shaking really hard. So instead, I just decided to record myself just in the middle of the night, like super manic. And I rewatched that recording, and I was just like, yikes. But I know a lot of people don't really know what mania is like, or like they're curious about what it's like to have like a manic episode. And this isn't like the worst episode that I've had by any means. Like worst episode, I cut off my hair. One of the worst episodes. I actually overdosed in another bad episode. So yeah, this is definitely not the worst. But I think just like the way I'm talking and like how my attention span is very short, and like things that I'm saying aren't making any sense, and I think it's all like overall like a good representation of mania. So yeah, I'm just gonna insert the clip right here so you guys can see for yourself, and I can stop talking about it. I don't know why I'm describing it when you can just see it. Coming to a genius realization. Just needed to move. I don't know why I needed to move. Listen, sit on the floor. Okay, so I just came to so I was just shuffle playing my music. Okay, I was just shuffle playing it. Like anything could come on. I don't know what's gonna come on. And then put it down right here. Okay, am I gonna put you down? I don't know how to put you down. Just stay somewhere, phone. Okay, let's see. You stayed. Okay, so I don't like this here because I can see the mess. Are you okay? Okay, so I'm going to go over here to this side of the floor. Okay, so I just had this genius realization, and I was just like, I need to just tell myself. Okay, so Stockholm Syndrome by One Direction. It is the perfect depiction of mania. Like everything about that song, like even from the beginning, like I don't remember what the beginning is, but and then they're like, I know they'll be coming to find me soon because eventually someone's gonna get me and someone's gonna be like, get better and like stop this and like whatever. Okay, like you just or just I'll be like that, or like I felt like someone was in my house the other day, and so I was just but whatever. So then that's when it gets to.
So we see those feelings of grandiosity. She's talking about her genius idea, but she's also really not making any sort of sense. She's sort of just stream of consciousness rambling. And she's also all over the place. She's moving around. She doesn't know why she's moving. She's losing her train of thought. She is trying to tell us about this genius idea she had, but then she can't even remember the beginning of the song. So I like this. I think this is a useful way to sort of see what one example of a manic episode looks like. We hear a lot about bipolar depression in the media. In fact, if you see somebody displaying sort of odd patterns of behavior, it's really common to go, oh, that person's acting bipolar. So I'm hoping that some of this lecture and this week will help to sort of dispel some of those myths and see what it means to be bipolar is just having these manic and depressive alternating episodes. It doesn't necessarily mean you have split personalities, which I think we tend to hear a lot. Okay, so you can watch the rest of that if you want to. I am sorry that we're ending on such a bummer note, but I do want to touch on suicide. Suicide in the United States has been on the rise. It's up 33% from 1999 through 2017. The pace of the increase has been pretty steadily rising since 2006. So in 2016, suicide ranked as the 10th leading cause of death among Americans. It's the second leading cause of death for those under the age of 35. Official statistics and research studies have found that there are a number of gender differences in suicide. So these differences are known as the gender paradox. So while females are more likely to experience suicidal thoughts, for example, males are much more likely to actually take their own lives. Women are roughly 3 times more likely to attempt suicide, although men are 2 to 4 times more likely to die by suicide. Compared to their male counterparts, women show higher rates of suicidal thinking, non-fatal suicidal behavior, and attempts. Now, the differences in attempts and completed suicides in women have erroneously led people to believe that suicide attempts in women are often a method of gaining attention rather than a serious risk. This is not true. So it is important to note that among women, an attempted but failed attempt is often the greatest risk factor for suicide in the future. All suicide attempts, whether in men or women, need to be taken extremely seriously. One of the most important reasons for the difference between attempts and completed suicides between men and women is the method used. Men tend to choose violent and more lethal methods, such as firearms, hanging, or asphyxiation, where women are more likely to overdose on medications or drugs or things that can be more easily interrupted. Other risk factors include, but are not limited to, previous suicide attempts, feelings of hopelessness, family history of suicide, and access to preferable lethal means. So how able are you to get your hands on pills or firearms? For each completed suicide, there are usually between 8 and 25 attempts that come before it. So many times people will try many times before they're actually able to complete the suicide. So I know this is a difficult topic. I know this whole lecture consists of difficult topics. I encourage you to now go watch a funny cat video, or if you are feeling badly, to reach out to someone for support, or again, you can contact the Tuttleman Counseling Center. So that said, on our next section, we will talk about personality and dissociative disorders. So I will see you then.